Welcome to this session on hot topics within structural heart disease. It's divided in two parts. First, we're going to address the aortic valve, TAVR, and then the second part of it will be the mitral valve using transcatheter edge-to-edge repair. My name is Lars Sondergaard. I'm an interventional cardiologist based in Copenhagen, Denmark, and I'm very pleased to moderate this session with Raj Makkar from Los Angeles in the US. We got panelists as well. We got Dr. Harasida, Dr. An, Dr. Bang, and Dr. Yi. So I think without any further ado, we're going to start this with the first hot topic in TAVR, and that's around leaflet thrombosis and all the discussion where this is clinically relevant. So Dr. Park, please.
I'm gonna talking about the leaflet thrombosis after TAVR. Is it clinically relevant? This is my disclosure. So, and the last 10 years, there are many random trial have conduct, and all of a trial is from the old age to the younger age. Look back the all available, the random trial, all of the trial used the conventional regimen, the aspirin and plus clopidogrel. The decision is absolutely based on expert consensus. It is like a stat. So, and this paper and the co-moderator and the Raj Makkar reported in New England Journal of Medicine nearly 6 years ago, there is a risk of a possible subclinical leaflet thrombosis after TAVR valve, and the prevalence in the 13%, the small ID study 40%, overall 20%. Also, FDA perspective and make editorial perspective whether reduced leaflet motion is clinically meaningful or representative of subclinical advanced imaging phenomenon. The loss of leaflet mobility render the valve dysfunction and demand additional investigation. It's a two important unmet need regarding valve leaflet thrombosis. First, clinical relevance of leaflet thrombosis after TAVR, and second is the optimal antithrombotic therapy after TAVR. Should leaflet thrombosis be guided? So, and this is the Lars Sondergaard and Raj Makkar co-PI in the Reserve and Savory Registry published in Lancet Journal. The key finding: overall reduced leaflet motion 13% in TAVR, SAVR 3.6%, much lower. And the key finding after use of anticoagulation warfarin or NOAC, overall instance of leaflet thrombosis much smaller. And one of the key finding is clinical impact and stroke or TIA. Although this is observational data, the composite of stroke of TIA, the significantly higher in patient with leaflet thrombosis, and the stroke is that there would be some higher tendency. So this is also important findings. Lars Sondergaard reported the European Heart Journal, and the leaflet thrombosis reduced motion. This is a very dynamic change with the use and the antiplatelet. This instance of a halt hem increase with the use of anticoagulation is normal regression is much common. And this is report Raj Makkar partner 3 study. Is overall finding is similar. There is a very dynamic pattern of leaflet thrombosis. Leaflet thrombosis was much higher in the TAVR procedure. Also, although there was no statistical difference, numerically higher instance of a stroke or TIA, we did not provide a strong message about leaflet thrombosis and cerebral thromboembolism. So, and this is a recently published meta-analysis, and all data is mainly based on observational data. It's a 25 study published JAG intervention, and this is a key message, central illustration. The presence of leaflet thrombosis over 6% if untreated associated with increased stroke risk, relative risk 2.54, use anticoagulation 99% is the resolution. However, the limitation is overall finding is based on the observational study. And second part is optimal antithrombotic therapy after TAVR. Should leaflet thrombosis be guided, and I'm gonna briefly review the available data, popular TAVR study, evaluation, omission of the clopidogrel in no OAC group and OAC code, and the key finding is code B indicated for oral anticoagulation group, mainly atrial fibrillation patient, and the OAC alone was better, the reduction of all-cause bleeding. There is no the difference in the ischemic event. Code A, no indication for oral anticoagulation. We achieved the same finding. One of the big trial, Galileo trial, and the co-moderator is COPIA in this trial evaluated rivaroxaban. Its finding was disappointed. All clinical outcome, efficacy outcome, all-cause mortality, even bleeding outcome was poor with rivaroxaban. Although morphological data for the CT study with rivaroxaban use at much lower, however, clinical outcome was absolutely some different finding. Atlantis trial evaluated 1,500 patients, evaluated apixaban for patient indication for OAC, no indication for OAC. Overall finding compared to standard of care, apixaban did not achieve the better outcome in terms of safety and efficacy. One of the interesting finding in patients, no need for oral anticoagulation. All-cause mortality, especially non-cardiovascular mortality, was much higher with the apixaban use. The recently envisaged TAVR trial evaluated edoxaban in patients in atrial fibrillation. Overall finding, primary efficacy endpoint NACE was no difference. However, major bleeding much higher with edoxaban compared to warfarin. Still a main issue. The causal relationship of leaflet thrombosis with the cerebral thromboembolism and the possibility of neurological or neurocognitive dysfunction in patients with TAVR still unclear. Most available data absolutely based on observational data. Also, it is unknown direct oral anticoagulant edoxaban can reduce the occurrence of leaflet thrombosis accompanying cerebral thromboembolism risk after TAVR compared to antiplatelet therapy. This is our ADAPT TAVR trial. This is a multinational, multi-center trial to evaluate edoxaban effect in patients without long-term oral anticoagulation indication. And this study is a random trial, include more than 220 patients, and the randomization edoxaban versus DAPT therapy. DAPT therapy was a standard therapy at the time of the trial enrollment. This is targeting for patients not indicated for OAC. Study endpoint, the primary endpoint, the 6 months of 4D CT, the founded leaflet thrombosis. Secondary outcome, serial measured the cerebral embolic, the risk measured in DW MRI and the MRI series. Also, we measured neurocognitive neurologic function, NIS, modified ranking score, and MOCA. Also, we evaluated the echocardiographic parameter and clinical outcome. This is a summary, is how can you measure cardiac CT, routinely measured 6 months, brain MRI, post-TAVR, and the 6 months of follow-up serial change. And this modified ranking score, MOCA, was systematically measured. Also, is all measurement measured in COREF. And our trial will be presented in the April late-breaking clinical trial section 4. So the main tent, this is the presented late-breaking trial in the ACC meeting in the April 4th. So summary, leaflet thrombosis and antithrombotic strategy. TAVR patients have a multiple thrombotic and bleeding risk comorbidity. HALT or HAM is absolutely time-dependent dynamic phenomenon. Its clinical impact still unknown. The choice and duration antithrombotic therapy still remains a matter of hot debate, and the several RCT demonstrate less is more concept antithrombotic strategy was better. This is reflected in recent updated guideline. Potential role of edoxaban in patient without OHE indication. Also, true relationship of leaflet thrombosis and cerebrovascular embolization and associated neurological neurocognitive dysfunction will be confirmed by our ADAPT-TAVR trial, will be presented at ACC late-breaking clinical trial. Thank you for your attention.
It was excellent, Dr. Park. Dr. Sushil Kodali from Columbia University is going to touch on another hot topic, and that is if TAVR will replace all bioprosthetic surgical aortic valve replacement. Dr. Kodali.
Thank you, Raj. Thank you, everyone, for this opportunity to talk. So this is a great session, a lot of interesting topics. So I was tasked with the question, can TAVR replace all bioprosthetic AVR? These are my disclosures. So what's required to sort of make that statement a positive? First, you got to have results equivalent to or superior to surgery. And one of the things that we have in TAVR is a lot of data, but what's important to keep in mind that a lot of this is older data during the learning period of TAVR, data during the early iteration of devices. So when you go back to this data, it's not always as robust. And I think most of us would agree that TAVR is the preferred therapy in high-risk patients, but the initial trials showed it as comparable to surgery at 1 year, but that was early experience, early data. And we know that TAVR improves survival over medical therapy. We saw later data, again, still with the early generation device, that it's equivalent to, but maybe superior to surgery for death and stroke at early time points. But what we do know is over the years that with procedural iterations and device modifications, complications such as vascular, BVL, stroke, all continue to decrease. And the most recent large, robust data set is in the low-risk patients, and this is with the Edwards SAPIEN 3. And the 1 year endpoint showed for death, stroke, or rehospitalization, TAVR had a significantly lower rate at 1 year compared to surgical AVR. And even when you look at the individual endpoints, either death, stroke, or rehospitalization, they were all lower with TAVR than surgery, at least at 1 year. The core valve study, again, in low-risk patients, showed very good results in terms of death or disabling stroke, numerically lower, not significant, than surgery at the 2 year endpoint. And they showed good hemodynamics with larger valve areas than with surgical AVR. And so these two large data sets in low-risk patients showed that at least at the earlier time points, either 1 or 2 years, that TAVR had very low rates of moderate or greater PVL in low single digits, 1 to 2%. You know, the pacemaker rates in this series were a little bit higher with self-expanding, but you know, there's been data more recently that the rates may be more lower. At least with balloon expandable, they're comparable to surgery. And TAVR had lower rates of bleeding, acute kidney injury, and AFib at 30 days, which are all important clinical endpoints. So I think with this data set that's most recent, we see that TAVR results are equivalent to surgery. But it's important to keep in mind that these results were in selected patients, tricuspid valves, and it didn't include all anatomies. And so we can't extrapolate this data set to say it's comparable to surgery in all anatomies. And so for TAVR to really treat all anatomies, to replace SAVR, it has to have the ability to treat all anatomies. And the question is, these are just some examples, you know, bulky calcium effaced sinuses, bulky LVOT calcium, aortic root sort of pathology. You know, is TAVR going to work in these anatomies? And yes, can you do it? Probably, but you're going to get leak in some of these patients. We don't have devices that right now, I mean, Lotus, we had a good experience with this type of thing, but a lot of the devices now don't handle this type of pathology effectively. It may be okay in a high risk patient, but in a younger, lower risk patient, you're not going to accept mild to moderate PVL, in my opinion. You need to be less than mild or trace in these patients. So in these type of anatomies, TAVR may not accommodate. And the other big category that Raj has really published extensively on, has led sort of the data set with it, is bicuspid valves. You know, there's a lot of issues. They're asymmetric. You get gaps. You may seal. This heavily calcified raphe that we see with these type 1 bicuspids often push the valve asymmetrically and lead to root injury or annular rupture if we're not careful. Sometimes you can get non-circular deployment, as in this case with a balloon expandable, because of the asymmetry, and you see abnormal leaflet function in this particular example. And that could obviously lead to acute hemodynamic issues, although the gradients are okay in this case, but it'll probably lead to durability issues in the long term. And also there's a concomitant pathology, the aortic root stuff that we're not treating in bicuspid valve. So it may not be the ability to treat all of these scenarios. And what we're seeing, and this bicuspid classification, this is Hassan's work with Raj and others, that there's a lot of variability in what we mean by bicuspid, not only in the morphology of the leaflets, but also in the calcium patterns and other factors. And, we never thought about this with surgery, because with surgery, you cut out the leaflets. So it doesn't matter, these different classifications. You're cutting out the leaflets, you're putting in a circular valve, and you're sewing it in. It's a very different process. Whereas here with TAVR, it may perform differently in this anatomy than this anatomy than this anatomy. And that's where, and different devices may perform differently in different anatomies. And that's where we need to get the data set. What we do have is what Raj has published early on from the TVT registry. And this was a propensity match cohort of bicuspid versus tricuspid, 2,691 patients in each cohort. And, what you saw was, again, early experience sort of, but higher rates of annular rupture and conversion to open surgery, but still very low, less than 1%. Slightly higher rates of needing a second valve. But the other, in terms of device success and other endpoints, it really wasn't that different. And when you looked at, all-cause mortality, no difference at 30 days, stroke rates were higher, pacemaker rates were higher, but, not dramatically different between bicuspid and tricuspid. And when you looked at the one-year outcomes, really no difference between the two cohorts. PVL, which is one of the things that we were concerned about, again, the rates were relatively low of moderate, low single digits. And, the majority of patients, again, these are site reported, had none traced. So there are limitations to the analysis. There's a selection bias. These were patients that people thought were suitable for TAVR, so it doesn't include all bicuspids. They probably didn't have an aortopathy. They were probably generally, the risk is hard to control. These are site-reported outcomes with no core lab, 1-year follow-up, so limited, and no CEC to adjudicate these results. So what do we really need? We need data. We need a lot of data. But what populations? Is it young type 0 bicuspids? Is it elderly type 1s? We need data in all of them, but do we need randomized trials? And I think that's going to be hard to do. And if so, what endpoints? We're talking about a lot of concerns about acute injuries and acute procedural success, which I think we can manage, but what is this going to mean for durability? And so the question is, do we need new devices? Do we need dedicated TAVR valves? I think that's going to be difficult to accommodate all these anatomies. I think we need adjunctive devices, either decalcification methods, breaking up calcium, or lacerating leaflets to allow the current devices to expand symmetrically. And so leaflet modification is where we probably need to go. Next thing we need in terms of being able to treat replace surgery is the ability to manage concomitant disease. Coronary disease is an important piece. Anywhere from 20 to 50% of patients have concomitant coronary disease, and whether that impacts the safety of the procedure or the patient outcomes is an important question. And in these patients, coronary disease may be more difficult to manage after TAVR, especially with certain devices. We don't have a lot of data, but there's a lot of different trials. I think this one meta-analysis suggested that patients with coronary disease are increased risk of mortality post-TAVR, and it didn't matter whether you did the PCI before or after. And so we need to understand, what do we need to manage coronary disease for the safety of the procedure, but we also have to think of the impact of coronary disease on outcomes, right? If you have triple vessel disease, that may impact their outcome if you leave it alone. And so managing disease after can be difficult with some devices because you have this frame, and we have to understand that. And we have to understand what coronary disease to treat. And this is one trial that's ongoing, led by David Wood, Complete TAVR, looking at, should we treat these patients? Is it impacting outcomes? And these are important questions if we're going to replace TAVR. We have to understand which coronary disease do we need to treat, when do we need to treat it, and how do we need to treat it? And then other concomitant pathology, if you have aortic root, you can't leave that alone, so TAVR is not going to address it. Multivalvular disease. Early data suggested that when you leave severe MR alone, even if you fix the aortic valve, it leads to worse outcomes. If you leave severe TR alone, it leads to worse outcomes. So for TAVR to replace surgery, you need to be able to address the other concomitant valvular lesions. And how do you do that? In the same setting? How do you do that financially? Or do you do it in stage settings? If so, which do you do first? And how we manage that? We need to understand the treatment algorithm for handling multivalvular disease. And finally, question of durability. we're getting longer term data. This is from Lars and his group looking at 8-year outcomes showing comparable results. Again, the numbers get small out there, but that's encouraging. This is from the partner 2, sort of looking at structural valve deterioration led by Philippe Ribeiro. And we see with the SAPIEN 3, SAPIEN XT had higher failure rates, but with SAPIEN 3, it was pretty comparable in terms of all-cause bioprosthetic valve failure, and especially structural valve disease, to surgical valve with the SAPIEN 3. So encouraging. But the reality is, how durable does a TAVR need to be? It really depends on how long the patient's going to live. This is an old slide I made, but when you look at life tables, it changes by region. You need to be adequate for the patient, and it needs to get them through their life without surgery. And that goes to a lot of the conversations we're having now about lifetime management. You do TAVR in someone at 65, it fails in their late 70s. What do? Do you do a re-op surgery, or do you do redo TAVR? If you do a redo TAVR, there's concerns about patient prosthesis mismatch, concerns about coronary access. It's beyond the scope of this talk to really go into that, but there are significant concerns. And if you do TAVR at that point, what do you do if they live to the late 80s? And it's unlikely you're going to be able to do a third one inside. So, the goal for all of us is to minimize open heart procedures and avoid performing them when the patient is older and higher risk. And so, the TAVR first strategy may work, but it may not. And we have to keep that in mind. And so if we're asking the question, can we replace all bioprosthetic SAVR with TAVR? Right now, the answer is not yet, in my opinion. We need more data. We need better data. We need new devices. We need to understand this much better. Thank you very much.
Excellent, Sushil. That was a fantastic and a very comprehensive synopsis of this of the role of TAVR currently. So let's move on now and talk about yet another hot topic in TAVR, and that is about the role of TAVR in asymptomatic AS patients. And Dr. Philippe Genro, who's been leading, the field in this particular area and is a PI of one of the important studies, will talk to us about this topic.
Perfect. So thanks for the kind invitation and a very interesting topic in this session. And Sushil Kodali just talked about the lifetime of TAVR and durability, and now we're going to talk about maybe intervening even earlier. So I'm going to talk a little bit about severe AS with no symptoms, and discuss what is the role of TAVR eventually for these patients. For my disclosure, so I'm going to touch base first of all, defining what is severe AS with no symptom based on the guideline, the recent guideline. Just touch about how to take a medical history, the role of stress test, the new guidelines, and the update of ongoing trial and a recently published trial. So first of all, what is the guideline said about severe AS and no symptom? We had a recent guideline published in 2021, and there's 2 categories of severe AS, no symptom. The first one is what they call C1, where we have the peak velocity more than 4 meters per second, AVA less than 1, and normal ejection fraction. This is a typical severe AS, no symptom with normal EF, which is defined more than 50%, but this is changing recently, where 60% is probably perceived as more normal than 50. And then there's a C2 patient, the patient with severe AS and no symptom, but in this case, with lower EF, less than 50%. So C1 and C2 based on the stage of a current guideline. One thing which is very important with those patients is really to take a good medical history, because when we start to dig, we realize that a lot of those patients hide symptoms or attribute their symptoms to aging process and fatigue, etc. So it's very important. I'm not going to go into detail with that, but to really dig for symptoms, because most of these patients will be symptomatic when we start to be more specific with our question, and also ask a family member. And when we are in doubt of the symptoms, or the symptoms are vague, such as fatigue and slowing down, this is where the stress test is a good tool. And talking about the stress test, this is clearly a class 2A indication. When patient has severe AS with normal EF, with clear no symptom or vague symptoms, stress test could be done supervised with a doctor to confirm the absence or the presence of symptoms. Obviously, not doing a stress test when there's clear symptoms, or when the ejection fraction is less than 50%. And very important thing is to choose appropriately the stress test for the patient, the age, and the sex, gender. not to over push the patient where they all become symptomatic at some point. So we have some guidance from a prior publication of the appropriate predicted meds for age and gender. Always important to do it under close medical supervision. It's not a screening treadmill for coronary disease. For asymptomatic patients, there's a clear obstructive lesion at the valve level, and stop the test obviously as soon as there's symptom, drop of blood pressure or arrhythmia. And this is the two publications that we use for early TAVR actually to design what should be the stress test, how to do a stress test based on the age and the gender. I'm not going to go to the detail, but we provide some sort of chart what to expect, for example, for a 65 years old female. Well, you should not go more than 6.3 meds, for example, and you should expect at least 3.8 meds, which is 60% of the expected capacity of a patient. So there's some guidance to how to do a stress test for severe AS no symptom patient, which is totally different than coronary disease, where we go with the heart rate, maximal heart rate. And this is some example of stress tests that we use clinically. Obviously, for severe AS no symptom, the modified bruise should be the default stress test. And the bruise protocol, the standard bruise, should be reserved for very fit patient, younger patient that are training or used to use a treadmill. Because when you look at the bruise protocol, for example, the incline of 10% slope right away is pretty disturbing for an older patient. So start with a Norton protocol or a modified bruise for older sedentary patient. When to stop a stress test, and we're going to see what is the implication of those, is obviously when it's abnormal, we talk about limiting symptoms. So chest pain, dizziness or syncope at any time, and shortness of breath if it's limiting symptoms for the stress test. If you have a drop of blood pressure more than 10, there's different criteria out there, but one which is used in the guideline is a drop of more than 10 millimeter of systolic blood pressure at maximal intensity is one that is the most used. And when you have significant ventricular arrhythmia, more than 3 consecutive PVCs. The ST depression is very controversial because it could only be either strain on the with the LVH or coronary disease. So this is very, very debatable criteria when you have ST depression more than 205. But actually, it's mandate probably a coronary angiogram to rule out coronary disease. And this is a type of stress test that we did in the early TAVR trial. This is with patient permission. This is one of my colleagues, Dr. Kipperman, and you see the setup is you have a close supervision and you start very, very slow. And this is the maximal speed of the patient, which was negative, and we enrolled the patient. So you see at this age, we don't go fast, you just respect the appropriate medicine. This is another patient we have, 87 years old female, was asymptomatic, and because of her age, we used a Norton. And you can see we only have to go for 3 meds with her age. Maximum meds is 3.4 and the 60% is 2 meds. And this is the stage 1 Norton, and on the right, this is the stage 2. So she passed with flying color and she was asymptomatic with normal blood pressure. So when patients do have abnormal stress tests, and this is a meta-analysis or a summer review that we wrote a few years ago, approximately 50% of the patients with severe AS, no symptom, normal AF, will have a normal stress test. So I really highlight the need to do the stress test because this is a class 1 indication when you have a normal stress test to treat those patients. And why is it like that? Well, if you have abnormal stress tests with the criteria we discussed, you increase your cardiac death over the course of the 1 or 2 years by 6-fold. To be symptomatic on a treadmill is the same as being symptomatic in nature. So that's very important. Cannot stress enough the need to do a stress test or apparently asymptomatic patient. So how to manage those patients right now in the current guideline? Right now, there's 3 class 1 indications to do a surgical AVR or an AVR on those patients. The first one is when there's clear symptom during a stress test, like mentioned. The second one is when the EF is less than 50%. And then the third one, then there's a series 4 class 2A, namely if you have a drop of blood pressure during the stress test. If you have a peak velocity more than 5, this is a 2A for surgery. And if you're a low-risk surgical patient. And another one is if you have an increased NT-proBNP more than 3 times the normal, you can be in your low risk for surgery. And the last one is if you have actually an increase in peak velocity more than 0.3 per year on serial echo. and again, if you're low risk for surgery. So only targeting surgical AVR in low risk patient. And the last one, the class 2B, which is an addition in the new guideline, is if you have a drop of EF on serial echo to less than 60%. So we mentioned less than 50% being the class 1. If you have less than 60% and you will start at 75 and now you see 55, for example, on 3 serial echo, it's a class 2B for low risk surgical AVR. So again, the important thing here is all those guidelines apply to low risk surgical AVR when you talk about class 2A and 2B. So what about literature update on those topics? So we did a meta-analysis back in the day when we were designing early TAVR, and what we show is among 2,500 patients, medical clinical surveillance as an unadjusted 3.5-fold increase in all-cause mortality at a mean follow-up of 2 years. So when we look at surgical series, and those are all series of patients managed medically compared to surgery, you have an increase of 3.5-fold increased risk of mortality by clinical surveillance. Obviously, not randomized trial, and that was observational data. And then we have an updated meta-analysis performed by another group that show actually that clinical surveillance increased mortality by 2.5-fold all-cause mortality when we follow those patients. Obviously, those series are really retrospective. There's a bias why patients were treated medically and not treated more aggressively. So that's very difficult to change guideline based on those retrospective data. One of the best pieces of data we have out there is really this series by Lancelotti that was published in 2012, where we really took 150 patients, did a CVRS no symptom. He excluded all the patients with positive stress tests, was doing bicycle in Europe. And really follow those patients for over 2 years. And what we show is after 27 months of mean follow-up, 6% of those patients that were followed very, very regularly had a mortality, so 3% per year. And among them, 2%, so 1% per year were sudden death. So this is where those numbers come. If you follow a patient with severe AS, no symptom, with regular stress tests every 6 months, the sudden death will be 1% per year, despite an appropriate follow-up. And 47% at 2 years needing an AVR, a surgical AVR. So this is the number we use to power early TAVR, and so 3% mortality per year, 1% sudden death, and 50% conversion within 2 years. And that's what's almost replicated in a series of 500 patients, severe AS, no symptoms. And what they show is when you have surgical AVR, you had a better prognostic over the course of time compared to no AVR. Obviously, the problem with those data is if you follow a patient for 12 years, when did the patient convert? It was at 1 year, 2 years, and when did he get AVR? It's hard to make a lot of sense of those data because patient can move category. And some patients were not followed carefully in those series, so that's make judgment difficult. And one key here is the important point is when you have an abnormal stress test, when you do less than 85% predicted meds, you have a poor prognosis. Meaning that if you do a stress test that's positive, you need to treat those patients. And when you look at all that, if you have a negative stress test and you have AVR, this is where you have the best chance of survival compared to if you have a positive stress test and no AVR. So I think those data are important and stress the need to do a stress test and maybe to intervene earlier. There is 2 recent studies actually that randomized trial actually that address these topics, early surgery compared to clinical surveillance. And this first study published by Khan and colleague in New England was very small, 145 patient, very young patient, 63 years old, 65 years old, mainly bicuspid. And those patients were critical AS. The peak velocity was 5.0 in average, and they were normal AF. There's no treadmill stress test done in those patients, and 50% had mechanical valve. And what you saw actually is a very convincing benefit on those patients in terms of operative mortality and mortality at 8 years follow-up. So you can see a strong win for early surgery on critical AS on patients that we don't know if they had a positive stress test or not. And that was also true for all-cause mortality. Recently at AHA, the Avatar trial was published recently in Circulation. Again, small study, 157 patient, only surgical AVR. You can see actually the incidence of mortality stroke and MI were lower in patient treated early with surgery compared to conservative treatment. So we have 2 randomized trials right now. Both are very small study, 145 patient and 157 patient, only done with surgical OVR, younger population, a lot of mechanical valve, and the low-level stress tests were not done systematically in those trials. So I think the jury is still out on these on this topic. But what we learned from these is if you have a young patient with critical AS, I think it's fair to send for surgery. Now the question is, what is the role of TAVR? So we have 3 other trials that are ongoing. So the early TAVR trial, where its enrollment has been complete, and the EVOLVE trial, which is Dr. Dweck leading the effort, mainly with surgery. And I'm very honored to share that the enrollment of the early TAVR trial, which will enroll 900 patients, 901 patients with systematic stress tests, and almost 95% of those patients is completed. We're going to follow those patients with severe AS, no symptom, normal AF, with negative stress tests for more than 10 years. And the primary endpoint is at 2 years, composite of cause death, stroke, and unplanned cardiovascular hospitalization. So those data will be available probably in 2024, as we just finished to enroll the last patient a couple of months ago. We're also going to have a registry where when the stress test was positive, what will happen with those patients, we can match with the other population. So very exciting data will come from early TAVR, and we'll see how it's turned out. So thank you for your attention, and very a pleasure to be among you guys.
Thank you very much, Philippe. So we have some time, 8 minutes for discussion, and let's start in the order of the topics as they were presented. So our first topic is about leaflet thrombosis. So, you know, I want the panelists to feel free to chime in, but while, you know, let's ask Kentaro, you know, about the issue of leaflet thrombosis. What, you know, what do you think? You think the dust has settled? Or, of course, I'm excited about the study that Park is going to present at the ACC on the relationship between this phenomenon and neurologic phenomenon. But what are your thoughts, Kentaro, about this topic?
Thank you very much, Raj. So actually, we didn't find the very significant impact of the leaflet thrombosis on the clinical outcome in the short-term and mid-term follow-up in our registry. And because in the history of TAVR, so we start from dual antiplatelet therapy, but we didn't see the subarachnoid thrombosis in PCI. And I'm not quite sure that we need to continue adapt or accept in this very elderly and high-risk cohort. But we need to know that we don't know the long-term effect or impact of leaflet thrombosis on durability anymore. So further study is awaited, I think.
Okay, I think that's an important thought. Now, you know, Lars, to engage you again, you know, since you've been in this field for a long time, tell us, if you had to design a important clinical trial, what would that be?
I think we need to know where this is going to have any impact on the patient outcome. And even though there are reports showing that these patients have almost a significant high rate of TIA stroke, remember there's always a gap between the CT scan confirming subclinical leaflet thrombosis and the clinical event. And since it's a dynamic phenomenon, we don't know what the status is of the leaflet at the time of the clinical events. So we actually have started here in Copenhagen a study with around 800 patients going to be enrolled, having different antithrombotic therapy for the first 3 months, either NOAC or antiplatelet therapy. And these patients are going to have a CT scan at 3 months, 1 year, 2 years, 3 years, 4 years, and 5 years. So that's going to give us information. What is the dynamic over time for these findings? And also, is it going to have any impact for the patient? Is it going to be associated with a high rate of stroke, TIA? And it will also impact the durability of these valves. I think that's probably one of the things we're missing just now with these snapshot reports we got on this phenomenon.
Mm-hmm. So, you know, I just, and I want to engage everyone, do you think we've all sort of accepted, right, from the Galileo study where the outcomes were worse with anticoagulation. And of course, other studies didn't really favor aggressive anticoagulation. And of course, even in terms of antiplatelet therapy, less was better, right? So the question is, do you think this story is all told, or do you think that given that we are treating younger patients now, there ought to be, some of these things need to be restudied? An average age of 80 years is very different from some of the patients that we are treating now. Should we do a Galileo 2, or, modified in younger patients with an upper age limit of 70 or 75, low risk bleeding score? So Dr. Park and Sushil and others, I just want to ask, feel free to chime in.
I can make just one comment. I mean, I think there's lots of unanswered questions, and the story's not written. It's, there's the acute results, but it's about the impact on durability. And I think we also don't understand. I think we need to get a better understanding of why some people develop it and others don't. Is it biologic? Is it flow? Is it valve type? If we get that understanding, then maybe we can modify designs, or we can selectively choose who benefits potentially from anticoagulation. And that conversation can be part of the conversation with the patient up front. And so for me right now, I think the energy needs to be focused on why some patients develop it, not necessarily the impact. Because, I don't think it's fair to say, it hasn't shown any clinical events. For me, if I see that plot on my leaflet, I don't want that, right? I mean, I think we can all agree on that. And so we need to better understand who gets it and then decide why, and maybe we can treat them or we can modify designs.
Okay, great. So our next topic was what Sushil presented, the penetration of TAVR. Will it replace all surgical aortic valve replacement? And we have Kaneko here, who's a surgeon. And so Kaneko, tell us what are your concerns? Of course, Sushil highlighted them, bicuspid is a big area, and you recently presented data on the, the outcomes of surgery with bicuspid aortic stenosis, and they were pretty good. So what do you think are the big showstoppers and how the field will evolve?
Raj, thank you so much for the question. I have to say that I see a lot of patients in clinic, and there's almost zero patients that comes into my clinic and says that they want surgery, right? Everyone wants TAVR. So I think that trend is going to continue. The conversation really has changed compared to 5 years ago. 5 years ago, we were thinking which patients were indicated for TAVR. All of the patients were considered for surgery. Whereas now we're thinking all patients as potential TAVR candidates, and we're thinking about which ones are going to be surgery. I think that boundary is going to be further tested. Some of the bicuspid patients do completely fine with TAVR, as you've shown, Raj. And I think some of the disease, some of the ambiguity that Sushil has shown, like concomitant coronary disease or concomitant valve disease, will definitely be treated with TAVR in the future. I think that boundary will continue to be tested in the next decade. So I think it's a very, very impactful, very interesting field, especially with the revised device designs that we expect in the future.
So Dr. Wang, TAVR is now picking up. There are multiple devices now available in China. And I think what happens in China will ultimately also determine what globally, the role of TAVR. So how do you think this will shape up in China, and how is it affecting your practice?
For me, the TAVR indication is extended a lot in China. Doesn't matter the patient is a low risk, middle risk, or a moderate risk or high risk. Even if the patient's age is big enough. So regularly in China, we cut the 65-year-old. If the larger should be okay. But I still concerned about for some patients with bicuspid aortic valve stenosis, especially the ascending aorta is large. I think we still need to figure out for this kind of patient, bicuspid aortic valve stenosis patient with ascending aorta dilatation, what is the cause of dilatation of ascending aorta? Still a little bit controversial. From our single center cohort observation, long-term observation, looks like for many of patients, the dilatation of ascending aorta coming from the hemodynamic factor, not the genetic factor. So for this kind of patient, if I think the saver is, if we are quite sure it's coming from the genetic. So at the same time, when we do the valve replacement, we need to change the ascending aorta. But if the dynamic factor, maybe TAVR is enough, we can keep on observation. Maybe the ascending aorta will not be changed in diameter. So that's my thinking. So I just put the question for discussion.
Okay. All right, and then the final topic was asymptomatic AS that Philippe presented on. So I just want to ask others on the panel here if somebody has immediate thoughts. But while I'm waiting for someone to speak up, I'll ask Samir. So Samir, in your practice, if you've got an asymptomatic AS patient, there are somebody with a valve area that is clearly tight, 0.7, but doesn't have an elevated BNP, has a gradient that is robust, more than 40 millimeters of mercury, based on the data that is already out there, the Korean study, and so will you actually treat that patient now?
I think, yeah, a very good question. So the first and foremost, at least in the clinical practice and with the data that are available, of course, we would like to enroll them in the trials and things like that if they're available. But if there is no LVH, LA size is normal, exercise tolerance is good, and if they are on a cusp where waiting a few years can buy them one less valve in their lifetime, or change our strategy of how we replace the bioprosthetic valve and what is the anatomy of the valve currently, so that you will get TAVR or SAVR or both, or valve in valve is possible in the future. This determines that what we would do in this asymptomatic patient. So if you say that the patient is 75, healthy, and the valve area is such that, and the progression is such that we can wait a couple of years, I would love to wait. If he was 70 years of age, healthy, otherwise good, I'm not so sure that if we can do SAVR or TAVR, it would not be that big a deal, because we are not going to, if he's going to live 90, 95, he's going to get another 2 valves. So the question is that the lifetime prediction, very, very hard, of course, to do. But if there is no end organ damage, mainly to the cardiac standpoint, then we can continue to observe them, is my sense.
Okay. So would you actually use something like cardiac MR to further risk stratify? Of course, there is the Scottish study that is ongoing right now, but Philippe, do you have any thoughts on that? And Lars has a hand up, so after that, yeah, Philippe?
Yeah, briefly, I can echo Samir's comments. So the early TAVR taught us a lot, and by doing the CAT scan or any type of imaging early, you learn a lot about how complex is the valve. Sometimes it's curb your enthusiasm a little bit when you see that there's massive LVOT calcium, the root is, the annulus is small, and et cetera, et cetera. So to do the imaging first help you to see how easy it will be and how risky the intervention will be. So if the patient is clearly symptomatic, we can have a tendency to wait. In terms of the MRI, and I think this is a very good question, and I'm glad to hear the word cardiac damage by Samir. I think it's, at the end of the day, it's all about that. When you see a patient with severe AS or even moderate AS, and there's already a lot of hemodynamic consequence of LVH, fibrosis, DLA, etc., I think waiting is just going to do nothing and just going to push the damage further up. So I think absolutely we enter an era where we're going to do more biomarker, maybe cardiac MRI, LV strain. And I think the stratification that will be the easiest or the simplest will allow us to maybe change the way we approach patient with AS. So absolutely.
Okay, Lars?
Yeah, I can only echo what Samir and Philippe is saying. I mean, this is now turning from being a prognostic procedure to be a prophylactic procedure from what we know today at least. So we need to make sure we have the optimal outcome for TAVR. So we should not engage in all kind of anatomy. If it's a very hostile anatomy for TAVR, we should think twice before we offer this patient with preserved left ventricular function these procedures.
Okay, so before we move, I want to ask Dr. Ye if he has any comments.
Thank you. I just give a little bit comments on the ACE. I think everybody give a very excellent balanced talk. I really like the talk. So the question is for the young patient. I think I still focus on the age. I think when you offer TAVR surgery, I think not just consider the initial risk and the outcome. I think we really need to focus on the future management. What's the risk for the reduce? I think that should be very, very seriously considered, especially you talk to the patient for the consent.
Okay, great. All right, so we have now another important session, and we'll get the other panelists involved, while we go to that. But Lars, you want to go ahead and actually introduce our next speaker?
Yeah, I can do that, Raj. So now we are changing from the aorta to the mitral valve, going to talk about transcatheter edge-to-edge repair. The first talk will be by Sybil Carr, who's going to talk about the role for transcatheter edge-to-edge repair in patients with primary mitral regurgitation who are considered at intermediate surgical risk. So Sybil, please.
Thank you, everybody. Thank you, Raj. Thank you, Lars, for allowing me to speak in this session. It is actually a little bit more controversial than the previous session. So we're talking about TEER and intermediate risk primary MR. Will it follow the same steps as TAVR? Transcatheter edge-to-edge repair at the moment is the only approved technology for the treatment of primary MR in most countries in the world. It is safe, it's effective, and durable even in selected patients. Used primarily in high surgical risk patients or inoperable patients at the present moment. Improvements of technology, imaging, clinical experience has led to a greater efficacy rate. There's also an increase in the use of this novel technology worldwide. And physicians and patients are keen for this therapy to go down to lower surgical risk patients. So here's a patient who's 75 years old, a Jehovah's Witness with mild mitral regurgitation, severe mitral regurgitation due to a flail P2 with mild mitral annular calcification. What would one do with this patient? There are going to be different approaches, surgery versus repair. So when you look at it, it could be a surgical repair. This is a standard of care for a low intermediate risk patient. You can do replacement since there's mild mitral annular calcification. You can do transcatheter edge-to-edge repair, and that would be off-label since it's not indicated for low intermediate risk patients. Or you can enroll the patient in a trial, surgery versus repair, since there's an equipoise in this group of patients. Now let's look at the treatment strategies based on the ACC guidelines. If you look at the ACC guidelines and you look at the treatment for chronic primary MR, which means usually degenerative MR, you can see the class 1 indication for treatment is surgical repair. It can be even up to patients with asymptomatic. If you look at the next column, which is B non-repair, you can see there's no randomized data supporting that. You can see the class 1 indications B non-randomized data. We now look at the indications of the chronic MR and go a little bit more further, and you can see that tricuspid edge-to-edge repair has a very narrow indication for only severely symptomatic patients who are high or even prohibitive risk for people. And then this is based on non-randomized data. It's actually the Everest 2 high-risk registry. You look at the last part of this guideline, which was not there in the previous guidelines. It's class 3, it's harm to consider treating a patient with a replacement if less than 50% of a posterior leaflet is involved, or if it's not even tried in a comprehensive valve center. Because if you take a patient and then you replace the valve with the P2 flare, it's considered to be harmful. putting that into perspective, let's look at what we have. Slides. So there's a significant undertreatment of mitral valve disease everywhere. And if you look at this community, you can see that only a small percentage of patients actually got treated with surgical repair. And if you left them untreated, compared to those who got treated, you can see that there was actually a mortality, which tells you that a lot of undertreated patients were left alone. And if you don't treat them, they actually do badly. Now, what exactly is a moderate surgical respiration for primary MR? If you look in the second column, this is again on basis ACC guidelines. A low surgical mitral valve patient will be considered where the STS score is less than 1, no frailty, no other cardiac issues, no procedural specific impediments. All of that is 1, then it's less than 1. That's considered a low risk patient. So actually, the low risk patients are actually much more low risk than compared to a low risk TAVR patient. If you now look at what patients are considered to be high surgical risk or prohibitive risk, look at the different 8% mortality, 2 frail indices, 1 or 2 organs involvement. So there's a lot. So you have a very large area between 1% and 8%, which we have nothing for or no classical determination. Now let's look at what data we have for this group of patients. If you look at the impact of age on mortality with mitral valve repair, remember all these patients were considered to be low risk. You can see over here that when you cross the age of 75, the mortality rate doubles. And this is in the STS case where obviously the surgeons chose patients who are operable. So age is a strong predictor of morbidity and mortality in mitral valve repair, with age of 75 being a key inflection endpoint. Now let's look at the actual data of how many patients get repaired in the United States. And this is based on the STS database. And what if you look at this, you can see that the majority of patients that get operated in the United States have an STS score of less than 1.2%. In fact, only 25% of patients who undergo surgical repair have an STS score of greater than 1.2%, which tells you have a huge group of patients in this moderate risk who are actually not getting any treatment or there's no guidelines for them. So let's look at transcatheter edge-to-edge repair. And I just should have added that there is another technology called Pascal. But if you look at this data, you can see now we are in the 4th generation of the MitraClip. There are over 150,000 patients done worldwide, where in the current 4th generation, we only have a limited indication for greater than 6%. And TEER with the Pascal device is available in Europe and is currently in a clinical trial in the US. Now let's look at the contemporary data. People always talk about inadequate results with edge-to-edge repair, and they usually quote the Everest 2 trial, which is not right, not wrong, where you can see a majority of patients, yes, went to 2+ or less, but 53% only actually had 1+ at discharge, and only 37% had 1+ at 1 year. So a majority is 2+. This is at 1 year. Now look at the EXPAND data, which we take the EXPAND registry, which is a contemporary registry of all comers done in the US and Europe. And if you only take the category of primary MR patients, which is a quite large subset, you can see that there was 279 patients, and 100% of this group had 3 or 4+ MR by the ASC criteria. 82% would have achieved 1+ MR at discharge, and the majority stayed consistent with 1+ at 1 year, and over 94% were actually 2+ or less. So you can see there's a significant difference between these 2 results over the 2 time period. And why did this happen? It happened for 3 good reasons. One, there was an improvement of technology, especially with the inclusion of a new size, the XTR. The second is the experience, and the third is, of course, imaging. Putting this together, this is probably what represents the contemporary data with transcatheter edge-to-edge repair. If you look at the contemporary data from the TVT registry, and if you look over here with patients who are older, you can see the same thing, that you can see that when you're older, like you're 77 plus, ejection fraction 2, you get a 30 days, 86.8% at 1 plus, and the 2-grade reduction in 95% of patients. So this leads us to the second stage, is what do we do with patients who are at intermediate risk? So based on this data, we feel that it's time to study a study on intermediate risk patients. Compare the clinical outcome of mitral clip versus surgical repair in patients with severe MR who are at moderate surgical risk and have a mitral valve conducive of repair. It's a prospective randomized multicenter trial to be conducted in United States, Canada, and in some states in Europe. All the data is going to be core lab adjudicated, and the data is going to be up to 10 years. And what it is we patients take severe primary MR, and a cardiac surgeon in the heart team has to agree that it's repairable by surgery, and it meets all the inclusion criteria, and the interventionist has to agree that he can repair the valve and get a result of 1 plus or less. And these are the inclusion criteria. The subject has to be symptomatic, but most important, look at this second box. That is the inclusion criteria. You have to have at least 75 years of age. So if you're 75 is above and your STS score is 0, you're acceptable, 75. Or if you're less than 75, if your STS score is 2% or more, or you have morbidities which make surgical repair a little challenging, but not inoperable. That means you can include a patient who's 62 years old, but if the STS score is 2 or they have morbidities, they get randomized 1-to-1 to surgical repair versus transcatheter mitral valve repair with a clip. Now, there are 2 primary endpoints, and I'm not going to show you all the secondary endpoints, but the 2 primary endpoints are different because one is on MR and the other one is clinical endpoints. And the core primary endpoint is all-cause mortality, stroke, cardiac hospitalization, or acute kidney injury requiring renal replacement therapy at 2 years. Any cardiac hospitalization the first 30 days post-treatment will be excluded. So we are not going to take in the first 30 days. If there's some admissions for heart failure, for AFib in surgical patients, we are going to exclude all of that. Also, the cardiac admissions have to be specific related to the disease. So if a patient comes in 5 years later due to an acute myocardial infarction, that's not going to be connected, that won't be added. The co-primary endpoint is the proportion of patients who have moderate or less MR. That means if you have patients who are greater than 3 plus, that's bad, or 2 plus. But if it's 2 plus or less, it's okay. Without the need of a mitral valve replacement, this is very important, and without the need of a recurrent mitral valve intervention, either surgical or percutaneous, from the time of the index procedure through 2 years. So this is the same patient who actually had 1 XTR, and you can see over here in 30 minutes, the patient went to trace mitral regurgitation. You can see the patient has a low ejection fraction. So that's why when you have older patients, sometimes the EF, which appears 50, goes up to 35%, and the patient, of course, did very well. So these are some of the types of data that you can get in patients who are at intermediate risk. So TR for my intermediate patient, what we do know is the procedural outcomes associated with mitral clip has improved significantly since the early Everest 2 clinical experience. Mitral valve disease continues to be undertreated in the community, where only a minority are treated undergoing surgical repair. With improvements in procedural outcome, imaging, and availability of new generation device, the time is now to bring a safe and effective treatment option for elderly patients who may be candidates for surgery, but may also benefit from mitral clip. The time is now to evaluate TR in intermediate risk. What do we conclude? TR for intermediate primary MR will follow the steps of TAVR. In fact, the people in TAVR actually showed us the footsteps. Repair MR as currently designed is the right trial for primary MR. There are other clinical trials in the same field. And the reason why I'm bringing this up is that the patient population and the associated benefit risk will help advance patient care for elderly patients. This trial is not a comparison between surgery and clip. This trial is an expansion indication to see that there's a group of patients who can benefit from both therapies. The randomized nature of the study is intended to increase and improve the guideline support for MitraClip. Thank you very much.
Yeah, Lars, please go ahead.
No, thanks, Simon. Great talk. It's very interesting topic here. We'll come back to the discussion a bit later. First, let's go to you, Samir, talking about disproportionate functional mitral regurgitation. Is it conceptual or practical?
Thank you very much for the invitation and a great topic, disproportionate functional mitral regurgitation. So first and foremost, why did this, I have no conflict of interest. Why this topic came in perspective. The reason for the editorial, reason for all this idea that why there is a disproportionate or proportionate MR came from this idea that COAPT and MITRA-FR had two different results. MITRA-FR was negative, COAPT was positive, and maybe we need to find a reason why there is a difference between the two. As you all know, there are several reasons, including follow-ups, number of patients, but people focused on this part to say that the EROA was different and the regurgitant volume was different. EF was somewhat similar, but the size of the heart was different. So these were the reasons to understand that if this was the cause or not. So as I point out here, the trial design was different, the patient selection was different, procedural outcomes were different. But one of the reasons was this idea of so-called discordant mitral regurgitation. Now, what was the idea? So Paul Graben wrote this nice editorial to say that what is a discordant or disproportionate mitral regurgitation, what is a proportionate mitral regurgitation? Simple concept. Concept is that if the LV and diastolic volume is large and your EROA is small, meaning that you have a dilated ventricle, but your mitral valve is not leaking as much, then it is a proportionate MR. And if you are going to have a lot of mitral regurgitation compared to your LV dysfunction, then you are going to have disproportionate mitral regurgitation. The concept is that if the mitral regurgitation is the primary cause of decompensation, then treating mitral regurgitation makes sense. So this was a very simple, simplistic concept of treating the patient, but it has a lot of different implications. If you say a patient with a reduced ejection fraction and heart failure, as you all know that the patients with a reduced ejection fraction and heart failure have a low cardiac index and high filling pressures. So if you take these patients with the low cardiac index and high filling pressures, that can be from many reasons. So there can be low EF, mitral regurgitation, tricuspid regurgitation, atrial fibrillation. And now if you combine, let's say that there is a patient like this, and now you try to understand this patient and try to say that the patient's EF is 30%, MR is 4+, TR is 3+, has atrial fibrillation. And you can come up with the idea that maybe this patient, the reason why they have low cardiac index or high filling pressure, EF contributes 20% to this, MR contributes 50% to this, or TR contributes 20% to this, AFib 10%, or the other way. And then in the first idea, you would call it disproportionate, meaning that MR is contributing a lot to decompensation. And in the other concept, you will say EF is contributing more. How do we determine this? How do we come to this conclusion when you have a patient in one time point where you see EF, MR, TR, and AFib in a patient, that is it disproportionate or is it proportional? So again, there are many, many factors. So if you look at the LV and diastolic and EROA, and if you make the EF constant, so EF is 30%, and then you put the blood pressure stable, meaning the peak MR velocity of 5 meters per second. So that means the blood pressure is the same. And now if you say that what is the regurgitant fraction, 20%, 35%, 50%, 65%, then you would say that if EROA is 4, and if you have a very large regurgitant fraction, then you would consider it disproportionate, meaning that the MR is more important. Or if you are here where you have very little mitral valve leaking, then you will consider that is proportional, meaning that if your LV and diastolic volume is very high, then you will be more likely to be proportionate. And if your LV and diastolic volume is low, then you're more likely to be disproportionate. concept is that if you have an inferior wall MI and LV dysfunction is not that bad and you have severe MR, which is functional because of restriction, then obviously it is a disproportionate MR. And if you take care of the MR, patients will do better. The question is that if you are going to have a patient with bad EF, but regurgitant fraction of 35%, should we not treat them? Should we say that, hey, listen, this MR is not so important, your EF is more important? Is it a fair statement to make? The concept, in my opinion, is no, but I'm going to try to address that. So whenever you are going to have the mitral regurgitation and heart failure, there are at least three parts that I see. This is a three-dimensional figure, supposed to be, to say that there is a mitral regurgitation, LA and LV dysfunction, and LA and LV dysfunction. So if you have severe mitral regurgitation with less LA and LV dysfunction, treat it, no problem. If you are in the moderate range, where things are moving, where LA and LV dysfunction has come up, again, treating severe mitral regurgitation makes sense. This is the question, that should we be in the red zone when you are going to have less mitral regurgitation, but very severe LA and LV dysfunction? The question is questionable, because what therapy are you going to offer to the patient? If the therapy is to say that we are going to replace the mitral valve with 10% mortality, probably not. But if you are going to do some procedure that is going to be less than 1% mortality, then maybe it is worth it to treat this mitral regurgitation. What are the limitations to this concept? So there are three major parts. The one is that the dynamic nature of mitral regurgitation. So whenever we are saying that this regurgitant volume is this much, regurgitant fraction is this much, this is a problem. So if here you look at it, this same patient, TEE, very common, right? All of us see this all the time, that the TEE on the TTE shows a lot of MR, TEE in the same patient next day shows not much MR because, the guy is sedated. If you take this patient, another patient with a blood pressure while we are doing mitral clip, there is that much MR with a low blood pressure, and when your blood pressure increases, it's torrential MR. So, and you see that the leaflets don't even coapt on the top left. So this is the problem. When you say disproportionate or proportionate, remember the LV and diastolic volumes are the same. Same way here, this is the same patient that we are trying to organize our thoughts to say we are going to measure PISA. Of course, it's leaking all around. So again, it's not easy to measure these things. And the time period to the gap is same even if the LV and diastolic pressure and volume doesn't change. The other important thing to recognize is that many times the MR is not holosystolic. It happens in some places and does not happen in the other places. So how you measure the PISA and characterize is difficult. Now, this is an interesting patient, just referred to us last week. Say that patient has very severe symptomatic mitral regurgitation. And now, as you see, this is fairly large, but not the most torrential MR that you see. LV, as you can see, there is an LAD infarct. The patient has poor LV function. Patient is clearly symptomatic. Luckily, the patient was followed in Cleveland Clinic all throughout. So 7 years ago, he had an echocardiogram like this. 7 years ago. So this is in 2015. And you can see that the mitral regurgitation was less, obviously. LV was equally dilated. And patient at that time was not as symptomatic. We have all the data. So LV and diastolic volume, LV and systolic volume, ejection fraction, all absolutely the same, all throughout. It didn't change, it didn't dilate, it didn't do anything. Patient remained in atrial fibrillation with then and now. The most important thing that happened in this patient was this LA volume increased. So the LA got bigger, annulus stretched, and now he's leaking more, the mitral valve. And now the guy is symptomatic. Should we have treated him when his MR was moderate if we had a therapy that was easy enough to treat? So is this MR proportionate or disproportionate? Does it really matter? In my mind, it doesn't matter, because now the guy is symptomatic with MR. This is the only thing we can treat. LV function is not treatable. So there is nothing much to decide if the patient is symptomatic with increased MR and LSIs. Should we have treated him earlier? That's a good question. And is this a tertiary MR? Meaning that if the LV function was very similar before and LV function is same now, why did the LA dilate? Why did the annulus dilate? is it because of the little bit of MR that you saw in 2015, not little bit, but moderate, and with exertion, it may be more. So this created a tertiary MR. So if we prevented the MR at the earlier point, so the disproportionate, proportionate doesn't really matter. If you have a treatment that you can provide earlier on, which is safe, can we really make a difference? Of course, in this patient, we did a mitral clip and the patient did, very well, symptomatically doing well. Should we treat the mitral regurgitation early? So this is the trial that I want to highlight, because this is the trial that we designed, which is now called Empower trial. So what is the Empower trial? So Empower trial is a trial with Carillon device. All of you know the Carillon device. This has been there. The idea is that there are two different data sets that we are available. These are randomized patients, small numbers, but whether we treat mild MR, whether that makes a difference, core lab adjudicated, sham controlled, randomized. So the data quality is good. The number of patients are less. And if you look at the data, what it shows is that if you have 68 patients, so small number, but 1 to 2 plus MR. So these are the patients who are not really having a lot of MR. And if you treat these patients, everything gets better. All the things improve, their 6-minute walk, their LV and diastolic volume, systolic volume, LA, everything got a little bit better over time. So this is, of course, small number of patients. So this is why we are doing a large trial. But this is an important thing to keep in mind, that this is a device that is 10 French IJ. So it's like putting a swan, and you're putting a device in somebody with very little risks. So even if it does not provide a great benefit, at least we are not creating harm, and we are not eliminating any future options. So if you want to do a valve-in-valve, you're doing a CRT, you want to do a mitral clip, you can still see the leaflets. And interestingly enough, in this patient population, people with LV dysfunction, as you would imagine, sorry about that, as you would imagine, the people with LV dysfunction did better, meaning that if the LV was not dilated, then obviously the effects were not as important, because probably the LA or the annular dilatation was not there. So the way that this trial is designed now is we are going to have, as you see that here, 225 patients in each arm. So it is a 300 patient trial. So 150 patients in each arm, interim analysis halfway. So 150 patients in each arm, and it is a endpoint which includes mitral valve surgery or other percutaneous therapies. So if you are going to treat them early, any mitral regurgitation, if you treat them early, and if you require a mitral clip or if you require a mitral valve surgery, then this is an endpoint to decide that which one does better. And it's a sham control study, because again, we have to do the coronary sinus edge. So the conclusion, is it the disproportionate or functional mitral regurgitation is conceptual or it is practical? I personally feel that it's more of a conceptual idea, which is of usefulness, to say that if your mitral regurgitation is not very severe, you don't want to expand a lot of energy and risks to treat it if you are going to be a risky procedure. But if you are going to treat it simply without a lot of risk, be it a mitral clip, because again, mitral clip is super risk-free in most situations. So be it mitral clip or some other technologies, for example, like Carillon, then these are the important options for the patient. So they should not be denied to say that this MR is proportionate and we should not treat this MR, in my opinion. So, and I didn't go into the data from analysis of the COAP trial, but we did not find the difference if they were so-called proportionate or disproportionate when we analyzed the data. So I'll stop there and we'll take the questions.
Okay, Samir, so let's go to the final talk before we have a discussion on these three issues here. So we're going to talk about increased transmitral pressure gradient after edge-to-edge repair. Is it too much or is it too small, or it's a little? So Dr. Kang from Korea, please.
Thank you for your kind introduction. I'm Dr. Do Young-gang from Asan Medical Center. Today I will talk about the increased transmitral pressure gradient after TEER. I have nothing to disclose. Let's begin with the case. male 68 patient dialed DCMP and reduced ejection fraction 25% with severe functional MR. He was inotropes dependent and could not be discharged. And we checked the TE before the procedure, and MV area was 6.6, sufficiently large, and maximum mitral valve pressure gradient was 8. And baseline LA pressure was 70, and mean 48 millimeter mercury. After pulling first clip, still there was significant residual MR, but pressure gradient after first XTW clip was 4 to 5 millimeter mercury. It was a little bit higher, but because there was still significant MR, we added one more clip with XT, and the mitral pressure gradient was stable even after 2 clips implanted, and the residual MR was mild. And after the procedure on the next day, the TT showed mild MR. However, there was some limitation of the mitral valve area, 1.9 square centimeter, with a little bit increased mitral valve mean pressure gradient 7. And how would be the patient? How would be the outcome of this patient? TEER reduces mitral valve area, therefore it increases mitral valve gradient. The cyanide group showed beautifully that the mitral valve area after TEER decreases and then transmitral pressure gradient increases. And then reduction of mitral regurgitation versus increased transmitral pressure gradient. That would be a double-edged sword. And the definition of mitral stenosis is that the pressure gradient more than 5 means the moderate MS with the mitral valve area less than 1.5. Because after clipping, drawing the mitral valve area is a little bit difficult. So usually we use the diastolic mitral flow pattern after clipping. And that it gives the number of the mean pressure gradient, and usually more than 5 looks significant increased pressure gradient. And there are some predictors known for increased mitral valve gradient after TEER. Smaller mitral valve orifice area before procedure, and increased mitral gradient before procedure is a strong predictor of increased mitral valve gradient after procedure. Also, mitral annular calcification and the patient undergoing hemodialysis and more clips used and higher residual MR, that means increased blood flow over mitral valve, are strong predictors of increased mitral valve gradient. Then, what is the impact of increased gradient on clinical outcomes after mitral clip procedure? There are several reports from many registries, and the reduced mitral valve area was predictor of worse outcome in Cedars-Sinai single center registry from 2014 to 2015. The major of the patient was primary MR patient, and all-cause mortality and heart failure hospitalization was worse in the patient with smaller mitral valve area after mitral clip. Another German single center study from 2009 to 2014 with a majority with a secondary MR showed that the worst clinical outcome of all-cause mortality, surgery, VAD, or lead procedure was worse with the higher degree of residual MR and worse with the higher degree of the mitral valve gradient, 5 on the invasive measure and 4.4 by echo measurement. But the graph still shows that the patient with a smaller degree of residual MR shows better clinical outcome compared with the patient with higher degree of the residual MR. It seems that the analysis shows that the increased mitral valve pressure gradient and residual MR were independent predictors, but the graph seems that the residual MR degree would be a little bit more important for the clinical outcome prediction. And also in many subsequent registry data showed that the post-mitral clip pressure gradient higher gradient was associated with the worst clinical outcomes. And another ACCS TVT registry data, or large data, was presented in TCT 2018. And 14% of patients had the pressure gradient more than 5. And the patient was with the ESRD and higher baseline mitral valve gradient or smaller mitral valve area before procedure showed higher gradient. Also, the patient with the MAC or leaflet calcification was more frequent in the higher mitral pressure gradient patient. And also, the patient with the higher gradient has more severe or moderate residual regurgitation and all-cause mortality or heart failure hospitalization was higher in the patient with the higher mitral valve gradient. So we can say that the increased mitral valve pressure gradient was predictive of long-term clinical outcome. But another German single-center study showed that the relationship of the worst clinical outcome with the increased pressure gradient was shown in degenerative MR. However, if the relationship was reversed and not significant in functional MR patient. The German study showed that the residual MR gradient was significant predictor of the clinical outcome. However, the increased pressure gradient was not in functional MR patient. Recently, the COAP trial sub-study showed that the MR patient, the clinical impact of the pressure gradient after mitral clip. And surprisingly, there was no clinical outcome difference in death or heart failure hospitalization by residual mitral valve gradient. When they checked the data by the continuous variable, there was also no difference between mitral valve gradient and clinical outcomes. Also, when considering the CyberCars data, that the benefit of mitral regurgitation reduction is very important on clinical outcomes and the health benefits, that we can consider the benefit of mitral regurgitation reduction might outweigh the adverse effect of increased mitral valve gradient in COAP population. So in conclusion, increased mitral valve gradient after TEER was associated with the worst clinical outcomes in the majority of the clinical studies. However, it showed debatable impact in secondary MR in recent data. The mitral valve gradient is influenced not only by mitral valve area, but also by transmitral flow. So when measuring the mitral valve gradient, you must check the heart rate, cardiac output, and residual mitral regurgitation amount. So if the patient shows high gradient, even with a large mitral valve area, there can be significant residual MR or tachycardia can make some happen. And if the patient has a small mitral valve area, but still shows low gradient, and then checking whether the patient has a low stroke volume or increased LV and diastolic pressure or low LA pressure or bradycardiac condition before deploying the clip would be help to minimize the increased transmitral gradient. So let me conclude my talk. Increased mitral valve gradient over 5 mm mercury was associated with worse prognosis after TEER. However, benefits of MR reduction might outweigh the adverse effect of increased mitral valve gradient, especially in secondary MR patients with COAP data. And we need larger sized, longer term clinical data. And the art of balancing MR reduction and mitral valve gradient is needed. Selecting optimal candidate and procedural strategy for TEER would be the key to obtain best clinical outcomes. Thank you for your attention.
So Lars, you want to, while you're gathering Lars, you're on mute.
So maybe I can just start asking Saibal about this study here about intermediate risk patients. We also in the TAVI field was talking about low-risk patients and then realized that these patients, despite they're classified as low risk, are still elderly patients. So now what we focus on is more patients with longer life expectancy. Is that the same story here for the patient you now are studying? You call them intermediate risk patients, but it's still elderly patients. You're 75 years of age or older, and if they're younger, they need to have significant comorbidity.
We don't know what the demographics are going to be in this trial, but we think they will be in their 70s. Most likely they will be in the 70s. Few will be in less than 70 because it's unlikely to have, excepting with those who have risk factors. But they will definitely have a longer life expectancy because we feel this is going to be a long follow-up of 10 years. So we expect that we are going to see people surviving. And actually, mortality may not be even different. And we've seen that in the Everest 2 trial, that even at 5 years, there was absolutely no difference in mortality between MitraClip and surgery. So we will see, I think, much more longer follow-up in these patients. But I don't think they'll be in the 60s.
Yeah, but Saibal, why not learn? Since you're talking about being in the footsteps of TAVR, why not learn? We used up an entire decade. And maybe it was necessary with TAVR because the mortality from TAVR procedures used to be high when we first started and the technology took time to evolve. The safety of MitraClip is amazing, right? And you showed in your STS database that the mortality, even in the lowest risk of patients, was about 1.5%. So why would you not make the argument to actually, in fact, I would say that you could do an Everest 2 in degenerative MR. You know, in the earliest days, we treated 30-year-old patient, right? So why not go to even lower risk patients and younger patients?
Raj, it's nice to see you, by the way. And I'm happy that you're in the study, by the way. And I know you'll do very well. So Raj, there's a lot of controversy. First of all, we have to see there's a slightly difference between TAVR and studies because surgical repair, and actually somebody is on the phone, surgical repair is one of the few operations that cardiac surgeons do, which is almost a cure. Do you agree with that? I mean, it's different from a replacement, which has a lifespan, not the surgery, the lifespan of the implant. But surgical repair, when done well, lasts very long. So when you take a younger patient, let's take a 60-year-old patient with a degenerative MR prolapse, and you do a good surgical repair, what do you think is the life expectancy of that repair? Over 10 years. And we know that from non-randomized trial data. That's why we think before we step onto lower risk patients, we have to go carefully with intermediate, and only if we can show that we are showing sustained benefit for 4 or 5 years, will we go into a lower risk patient. That's why I know it's going to take time, Raj. It is going to take time. It has to be step release, but we don't want to make a mistake of then taking 2 low risk patients and then having a problem, because we do know that if you do a good edge-to-edge repair, Raj, and if it gets worse after 6, 7 years, 8 years, the options are few. On the other hand, if you have a good surgical repair patient with artificial cords, and it gets worse after 5, 6 years, or even 8 years, you can actually clip that patient. So that's why, Raj, I think we would rather be careful now. The other thing, Raj, is that this study is not trying to say surgery is better than clip or clip better than surgery. And you know there's a certain study by your colleague which is trying to prove that point. That's not the point. The point is to find a population of patients which can benefit both from surgical repair as well as mitral clip. The idea is not to show that surgery is a better option or clip is a better option. Because at the present moment, Raj, we only have a very, very limited indication for primary MR. So that's why I think it's better. I still think we can go to lower risk patients, but you have to see the data in intermediate before you jump there. And I'll show that.
Yeah. So Samir, do you subscribe to that we have to wait for a whole decade? We have to wait for another 10 years before we can actually use a clip for a P2 flail in a 65-year-old patient, or study that in a randomized clinical setting?
So this is, of course, a little bit a challenging question, as you rightly point out to me. I think personally that we are ready to investigate that. Saibal, I agree with you that the surgery is a cure in many of these patients. But if we select the right kind of a patient, so with a, let's say, a P2 flail and a one clip, and the other rest of the leaflets are good, and there is a nice valve to put a clip. Now we know where the clip works. At least with so much experience, we are much better in knowing where the clip works. Since we know where the clip works, I personally think that it is different than in the TAVR world, where we were fighting with the devices. You know, we had XT and AVO, so there is paravalvular leak and all these issues. Here we are not fighting with the devices, and the device is mature. 25, 15 years, 17 years you have been using. So device is mature, and nothing is happening. So it's not going to change. So it's not like that there is a huge thing that's going to happen in the mitral clip in the next 2, 3, 4, 5 years. So if we are not going to change the device, if we know how to use the device, and if device is safe, none of the trials are going to answer the question 10 years from now. None of the trials are. So if we are going to do the trial, this is the trial to do. This is how I look at it. I agree with you that the question is going to be what happens 10 years later. God knows what happens 10 years later, because it is not possible for us to answer this question. So this is the challenge we face in the scientific literature, that the long-term outcomes in young patients are very important, but impossible to gather from a clinical trial that is going to be short-term. Same with low-risk trials, same with everything else we are doing with TAVR.
Yeah.
No, but the trial, Raj, is 10 years. And you don't have to go, Raj, to 10 years before you go to low risk. Let's say, Raj, in a trend of the primary endpoint is 2 years, correct? Mm-hmm. And you're going to see a trend by 3 years. If we start seeing a difference in hard endpoints, like cardiac hospitalizations, mortality, stroke, then of course, you can go ahead and go to a low risk group of patients. You don't have to wait for 10 years. But if we see a trend which is not different, or there's worsening, then you can say maybe this is not the group that we should treat. But if you don't have a defined population, Raj, you can actually have a problem in data. For example, if you have a very wide range of patients, you can't always be sure that both the groups will be equal. If you have a defined population, it's easier to make a comparison. So if you do a study of all comers, let's say I'll give you an example. You want all comers, 65. What if you have a bunch of high-risk patients in the surgical arm and a bunch of low-risk in the other side?
No, but those things can be overcome by pre-specified strata, how you randomize patients.
Yeah, but then you have to do multiple levels of stratifications, correct?
Yeah. So maybe we could try to move to the next question about indication. Based on your talk, Samir, are we intervening too late in these patients with functional mitral regurgitation? If you look at the guidelines, it's optimal medical treatments, it's CRT, and before edge-to-edge repair is coming in. How do you see the future in 10 years' time? Are we going to intervene earlier in these patients? I'm asking everyone.
My opinion, I kind of outlined, but maybe I'll happy to listen to Saibal to say that I personally think we should intervene early. That's my personal opinion. Because not that we ignore the guideline-directed medical therapy. After the guideline-directed medical therapy and CRT, if the mitral regurgitation is persistent, even if it is a significant mitral regurgitation, if the treatment is safe, we should intervene early. That is my personal bias.
So I have one question to Samir, and you define the proportionate and disproportionate. There is based on mitral FL, one negative trial, one is positive trial. My short question is, how do you define the maximum tolerated GDMT? We are available a lot of new drug, ARNI and SGLT2 inhibitor, or evaluating for the available for heart failure treatment. How can you define what is the maximum tolerated GDMT? Can you comment on that in any panel? And Samir?
Yeah, I mean, I can actually make a comment about that. For the trial purpose, it was necessary to make the maximum tolerated GDMT so that that variable is equal on both sides. But in reality, you don't need to do that. If you take a patient and you see he's responding to medical therapy and he still has MR, as Samir showed a case of pan-holosystolic MR, that's not going to change whether you give ARNI or any of the drugs. On the other hand, if you see a patient's blood pressure is 170 by 80 and his MR is only mid-systolic, yes, of course, if you treat them medically, they'll do better. So that is common sense. So we actually can do that. So there are certain pathologies that you can see straight away, like a restricted posterior leaflet with an eccentric MR. You know that's not going to change whether you increase the maximum dose, and you can treat them early.
And also the data for the maximum dose is only good for the beta blockers, and the blood pressure otherwise determines the other so-called maximum doses. So it is a very tough nut to crack, because as you know, if you give enough diuretics to people, you cannot give beta blockers and vasodilators. And so you have to minimize the diuretics, treat them with vasodilators, so it is an art, and this art is not available everywhere. So this is another common problem we see, is that people are referred to us with so-called good guideline-directed medical therapy, but the reason why they're limited is because they are drying them out so much that they cannot give vasodilators, and then everything is messed up. So it takes, so again, personally, I think that is much better and easier to do early treatment compared to educate heart failure doctors.
Yeah, and the two are complementary, right? Because CLIP will enable you to actually optimize
medical treatment, yes,
go up. Absolutely. And I actually also believe that the medical treatment helps optimize the results of CLIP too, because I think that in terms of leaflet, not having very leads and not having micro tears and all of those things.
Yeah.
So I think we need to use these together. It's not one or the other. We're getting, I think this has been a fabulous discussion. Lars, I will have you, you can have the last word, and we are told that we need to wrap up.
I just have one final question to you, Dr. Kang, about this transmitral gradient. And sometimes if you have a clip in and you still have residual gradient, you measure a too high residual regurgitation, you see a high gradient on Doppler, but this may be flow induced, and you have to make a prediction what's going to happen if you put a second clip in. Now, most of us will use an online direct pressure in the left atrium. Has anyone looked into have a direct pressure measurement with a catheter in the LV, one pressure measurement in the LA, to guide whether you should proceed to put the next clip in?
Actually, I do not have the experience of the direct measurement of LV and LA. How about
maybe someone else have it on the panel?
No, I don't. I only use direct left atrial pressure measurements, not racing. But to me, that's very important, Lars. If when I do a procedure, if there's a reduction of the V wave or the LA pressure drops, no matter what the gradient is, the patient is doing better. If on the other end, you put a clip in and the LA pressure goes up or the V wave goes up, no matter what the gradient is, you've done something bad. So that's why I always measure the LA pressure. And when and you don't have to do it immediately or later. As soon as you put the clip in, if you see there's a reduction of LA pressure or a change in V wave, no matter what happens, I know I've done something to the patient. On the other hand, if it goes up immediately, then you just take the clip out. And so that's what, so I use a very simple common sense. Regarding you quoted my paper on mitral valve gradient. We did show that if you reduce the MR significantly, and if you're left with a moderate gradient, the results actually are quite good for patients.
Okay. So I have a question. So which one is more important? The blood pressure elevation or the left atrial pressure down? Which one is more important to means a good result?
So the blood pressure elevation is a very good sign, actually, when you're doing a procedure. But immediate left atrial pressure reduction, because what happens is, this is the problem. If you do a mitral clip, the LA pressure drops, then the blood pressure goes up, and then the LA pressure goes up again. So you can't use it for over the next 1 hour. You have to show the change, immediate change when you put the clip in. That is very important.
Thank you.
Before
Very
my-
practical advice here at the end. So I want to thank all the speakers, the panelists, you, Raj. I think we had a very good discussion here on two hot topics within structural heart intervention. So enjoy the rest of the day, everyone. Hope to see you soon. Bye.
Thank you very much.
Thank you, guys.
Thank you
Nice to
very
see you,
much.
Raj.
Thank you.
Amar is
Thank
over
you.
here. He wants to say hi to you.
Thank you. Thank you. Thank you.
You guys.
Okay.
Bye bye.